Today we have Professor Azra Ismail, who's an assistant professor in biomedical informatics at global health at Emory University. She directs the CARE Lab, Collective Action and Research for Equity. Her research is on the design of AI systems that target health equity for marginalized communities and care workers. She has previously worked with Google's AI for Social Good team, Microsoft Research, and the Wadhwani Institute for AI and the United Nations Global Pulse. Dr. Ismail has a PhD in human-centered computing and an undergraduate degree in computer engineering from Georgia Tech. Thank you very much.
Thank you. Hi, everyone. Very excited to be here. And actually, I think this is an interesting time to be having a conversation about AI and health equity because a lot is changing very quickly. So I think this is a good crowd to have some of those conversations with. So let's see, where this discussion gets us. But just to kind of give some background. So as Ahmed mentioned, my training is in human-computer interaction, or HCI. I kind of shifted streams a bit. I'm now in a biomedical informatics department, and I work closely with folks in global health as well. So you'll see kind of this flavor of trying to build an interdisciplinary approach to answer some of these big questions that we now have around generative AI and its role in healthcare. You'll probably have more questions and answers by the end of this talk, so I just want to preface that. So really kind of hoping for a discussion, because I think a lot of the questions that we are grappling with are probably questions that you're encountering in your work, or maybe questions that you're interested in answering as well. So I think it could be a really productive discussion that we could have collectively. And the title for my talk today is Towards Culturally Sensitive LLMs in Reproductive Health. Lots of terms here to kind of think about, like what does culturally sensitive even mean when it comes to large language models? Are large language models appropriate in a context that's as sensitive as reproductive health? There's also this kind of meta conversation that's also happening right now around what are people's reproductive health rights, and how does that intersect with what the healthcare system is able to provide, and to what extent does that have to be self-managed or community managed, right? And a lot of those themes also connect with Adrian's talk earlier today. And a lot of these discussions, this is the team that's been doing this research. It's a collection of students and faculty across biomedical informatics, public health, nursing, obstetrics and gynecology, so clinicians, and then students, of course, from different walks of life. So we've been trying to build really an interdisciplinary focus in the department to tackle some of these questions. And a lot of my work is also motivated by these broader conversations, like I said, that are happening around reproductive justice, and what are the relationships between those conversations and what that means for healthcare research. And these are, it's worth kind of often zooming out and remembering that these are global conversations that are happening. It's easy to kind of get kind of stuck in the bubble of the United States, but there's a lot of global kind of conversations on this topic. And a lot of what's happening here in the US also has global implications. So a lot of kind of scope for cross-boundary collaboration and learning. And today I'll be talking about two of our studies that we've done recently. One is around, one is a mixed methods evaluation of generative AI and its potential for responding to questions around menopause. Menopause, as you may be aware, is often stigmatized, often an under-supported phase in a lot of women's lives. A lot of women find their concerns dismissed by clinicians. They might find that they lack social support. So you're increasingly seeing a lot of women create their own social support groups, go on social media, kind of try to make sense of their experiences in different ways. And we're increasingly seeing a lot of women also start to ask questions around menopause and reproductive health from conversational agents. So we were really interested in understanding what is the scope for that, what are the concerns, risks, and the path forward. And the second study that we've been doing is outside the US. So this is in India with a nonprofit called Maina Mahila Foundation. And then we've been building a large language model-based conversational agent that aims to provide information around reproductive health that is quote unquote culturally sensitive. So I'll be talking about some of the kinds of questions we've seen women ask. What are some of the concerns when you try to build this kind of system? What are some of the kinds of frameworks we might need to design? And again, some paths forward for that. So these two papers were recently accepted for the medical informatics conference in Europe and Kite this year. So let's start with the first study. And just some context setting. So really interested in understanding first what are the capabilities of large language models to respond to questions around reproductive health, especially in the case of menopause. And then what are the current gaps when it comes to performance and responding to queries in the space. And in terms of methods, so we first compiled a list of publicly available conversational agents. We tried to take into consideration multiple underlying large language models. So that included Gemini, GPT-4o, Llama, and then also more customized menopause-specific chatbots. So we came up with a list of 21 different chatbots, and most of them were GPT-based. So around 15 of those were menopause-focused chatbots that were built on top of GPT. So of those, then we picked the one that was best performing based on our interactions. So we ended up with a final list of 5 chatbots. And we then had 2 clinicians, 2 gynecologists on our team identify first a list of 20 commonly asked questions around menopause. So this was based on their experiences. And then they had to independently rank this list of 20 questions with which were the ones that were most frequently asked. And we ended up with a final list of 8 questions, which included topics like menopause status and treatment options and symptoms. And this was done because we would love to do this for like a larger set of questions, but we found that we really want to do a deeper evaluation first before going broader. And when it came to prompting, we had a standardized query that was framed as you're a medical chatbot that's interacting with patients. You have to provide clinically accurate responses. Your patient has asked XY, include sources in your response. We didn't quite deliberately explicitly say that this should be emotionally supportive, or this should be, following a certain format or following a certain kind of guideline, because we wanted to see what are the kind of default responses that a lot of these conversation agents come up with. And we ensured that memory was disabled. So it's not taking the history of questions that are being asked into consideration. And then part of the testing that we did was also around bias testing. So we had additional prompts that varied who was the patient in the situation. So based on race, based on insurance status, to test the objectivity of the responses. And then some of the questions that were compiled by the clinicians here am I in menopause? Is there a cure for menopause? Why are my periods, quote unquote, weird? Why have my periods changed? I can't seem to lose weight. Is this a symptom of menopause? I have decreased sex drive during menopause. What are my treatment options? Why do I feel agitated, anxious, frustrated, etc.? Is that menopause? Is there any medication? And why do I have brain fog? Is that part of menopause? So also keep in mind that these are questions that are framed by clinicians. So we haven't yet thought about how patients are going to ask these kinds of questions in practice. And that's something that we're starting to do now. But this was an initial attempt to understand, even from a clinician's perspective, what is the scope of these technologies to answer questions of this sort. And then we generated the responses from the multiple chatbots for these multiple questions, analyzed with a score evaluation framework, which I'll come to in a second. And then we also had the clinicians note some qualitative observations, and then had a focus group afterwards, essentially a consensus meeting to talk about how they went about their rating, because we found quite a bit of discrepancies in how the 2 clinicians evaluated the responses. And we also used SBERT to analyze semantic similarity here. And then in terms of the metric itself, so we analyzed a bunch of different metrics that are currently being used for evaluating responses of large language models. And this is the one that we felt reflected many of the things that are typically part of these evaluation frameworks. So this is the score framework that includes a team of researchers across Stanford and a few other places. And the metrics that they have focused on include safety, consensus, objectivity, reproducibility, and explainability. So safety, consensus, quite straightforward, making sure that these responses are safe for patient use, making sure that this aligns with medical consensus, objectivity, really kind of trying to understand if there's bias in the responses. Reproducibility is kind of making sure you get similar responses over multiple interactions. And then explainability is really kind of reflecting on whether the chatbot is clear on where the sources of information are coming from. So this was the framework that we went with for evaluation. And if you look at some of these are things that clinicians could directly rate, but others are very, very complicated and cumbersome for a clinician. So safety and consensus was straightforward. We generated the responses with the with the LLMs and had like a response sheet for the clinicians to put in the answers. But for things like objectivity, where we had multiple variations of the prompts, for reproducibility, where we generated the response with 2 independent people on our team, those were really, really hard for the clinicians because they kind of experienced fatigue very quickly trying to go through all of these kind of tons of responses. And this is just with, like I said, eight questions and five different large language models. And in terms of the scores that we got, so these were all scores from 1 to 5, with a 5 being the best rating. And we saw quite a bit of variation across the 2 clinicians. So there was a general trend that was similar. So both clinicians rated GPT-4o as the best here. They rated Menopause Coach, which was a GPT-based chatbot, as quite highly as well. But there were differences in terms of how they individually responded to, how they individually rated certain responses. So we saw especially a lot of variation across things like, okay, so just kind of high level first, Menopause Coach did really well, GPT-4o did really well. Meta AI and Gemini really struggled, especially in the case of providing explainability. And then in general, the responses were better than expected, but they often do not have responses to psychosocial and emotional support. But we saw a lot of disagreement across the clinicians. So especially in the case of safety and consensus, where you expect that the clinicians would have very similar feelings about the responses, there was actually not very high agreement. Even with explainability, there was relatively low agreement. So it was just kind of surprising to us. And even with the consensus meeting, it was hard to reconcile their 2 perspectives because they had different ideas of what was appropriate to tell a patient at what stage of their treatment, or depending on what age they are, and so forth. So that was something for us, which was an interesting learning experience, because we also wanted to understand what is the value in these kinds of evaluations. And, my training is also as an HCI researcher. We're used to doing a lot of participatory work, a lot of qualitative research. So I often come with some sense of skepticism around some of these evaluation metrics. And that was something that we really want to study further. So we really want to understand more deeply what are the right kinds of metrics that are actually in practice, both practical for clinicians to use, but also actually reflect how they think about the kinds of responses patients need to get. And again, kind of reiterating, so far it's just the clinician perspective. I imagine if you give the same responses to a patient, they might have very different feelings about this. And then in terms of bias testing as well, so in general, we found that the LLMs are pretty good about addressing race-based bias. So there were very minor instances of that, but we found that there was some sense of insurance bias. And this was really interesting because we saw, for instance, if you said that someone doesn't have private insurance, they maybe have public insurance or no insurance. There were less details in the responses. So it was kind of making this assumption that they might not have access to certain kinds of resources, perhaps, and hence maybe that's information that's not relevant to them. So it was something that was a little more nuanced than what we expected, but it was less referenced, less detailed information compared to those who were insured. And Yeah, so this is, like I said, a lot of questions emerging from our work, but this is a space that we're really looking to dive deeper into. And some of the things we're doing now is, we're starting a lot of participatory design work with patients to understand what kinds of questions they might have around menopause. We're also looking at social media data because we're seeing that a lot of data, there are a lot of conversations about menopause on platforms such as Reddit, which offer a lot of insight into the kinds of experiences women have. And it also offers a lot of insight into the kinds of questions they have, how they might frame them, the kind of language that they might use. So using that as a starting point to understand how to even start to design for something like this. And kind of critically, these systems, we don't expect them to offer any kind of diagnosis, any kind of prognosis. It's really just an initial point to support the person who's experiencing menopause, give them a little more insight into what the experiences, what are the experiences they might expect, validate some of those experiences, and offer them some kind of initial support as they go on that journey. So that was more kind of like a reflective exercise, more kind of looking at existing large language models. And then the second study, like I said, was really around designing our own system and really trying to understand what does it take to build something that is context dependent, that's culturally sensitive. And this is work that took place in Mumbai, in India. So there were a lot of elements around language, around culture, religion, what is appropriate in that particular context and not, diet, etc., which is very, very contextual. And there are multiple stakeholders in this context as well. So here you have the community members themselves who come from underserved communities, and most of the women who worked with the NGO, which is called Maina Mahila Foundation, came from underserved backgrounds. They lived in the neighboring slum area, and then you had women from the community that the foundation trained. These were called Rani workers, and they were basically provided digital skills and taught how to use the system. And they were the ones who would introduce the system to other women. They are the ones who did initial kind of generation of a data set of different kinds of questions that women might ask around reproductive health and so forth. And then you had other team members in the organization who, again, were from similar communities, but also had a lot of training around health literacies and both digital skills and health literacies. And they went door to door to encourage women to use the app, to understand how to get onboarded and so forth. So for this particular paper, we focused on the workers' perspective because we were starting out with first understanding. We didn't want to test something like this with community members immediately. We wanted to kind of test it in a controlled environment. So we tested it with these women who had more digital skills and had an understanding of what this project was about. And we took a lot of inspiration from community-based participatory design and participatory research, or CBPR. So initially, a big part of the process was recruiting women from the community. They were recruited by the MINA team, door to door. Then they got a lot of training, a lot of digital skills around how to use the app, how to record questions they might have, and so forth. And then a big part of the process was building the knowledge base. So MINA has been operating in this community for around 10 years now. They've developed a large library of content. And then a big part of what we needed to do was create a data set of the kinds of questions women have and then gold standard responses. So that was a big part of the process that was developed with community health workers and clinicians who were from that region because they understood the context in which these women were based. And then we had the chatbot development, which was built on top of GPT. And then we had a lot of iterative testing and evaluation and improvements. So a lot of ongoing conversations with the system are also around the choice of the model. GPT was used by the organization because they had access to credits to begin with, but now we've been pushing very hard to move to an open source model like Llama. The other challenge was language support. So GPT was the one that was best at supporting Hindi and specifically English, which is Hindi, but written with the English with the Roman script. And a lot of those factors also came into play. And let's see, yeah. And then just kind of wrapping up very quickly. So some of the pieces that that are relevant in terms of the chatbot architecture. So you had kind of the typical flow was you have a user prompt. Based on the prompt, you determine whether the conversational history is needed or not. And then you translate the user query and do some level of quote unquote grammar correction interpretation. And then that's passed to the retrieval augmented generation system. You extract the relevant knowledge from the database, append that with the user response, generate a response in a doctor's tone. Then you translate back the response from the LLM in the local language, and then you have to do some level of grammar correction. There's a dictionary that was developed to swap out words that were too medical with local terms. And then finally, there was a response that was generated and sent to the user. So there were kind of a number of checks that had to be done throughout the process. So there was, of course, the prompt tuning aspect, which involved a lot of experimentation. But even beyond that, there was a lot of steps before and after that had to be done to try to generate something that was appropriate for this context. And this was the interface that was used. So there was a custom app that called the Mina Bolo app that was developed. And essentially, there was an initial greeting message that would go out. And this is what English kind of looks like. And a user could either type in their own question. They could also use voice to text to provide their question. And then they could also click on generated sample questions and follow-up questions to get the conversation going. Right now, Mina has actually switched to using WhatsApp because WhatsApp is much more prevalent in the community, and that has a different set of challenges in terms of interaction on its own. But this was the one that was tested for this particular phase of the study. So kind of the broader question we were really hoping to answer is, how do we design a chatbot to be culturally sensitive in an underserved non-Western setting? And then what does culturally sensitive mean in this context? And of course, this has broader implications beyond this particular context. So coming to some of the findings from the study. So we generated essentially a list of around 2,000 user question response pairs. And we analyzed the topics that women were asking questions about and the style of questions and responses that were being generated by the large language model. And we found that a large chunk of these questions was around the use of contraceptive methods. And then a lot of questions were also around quote unquote family planning. A lot of this has to do with the kind of the general context in that region, where there's a large push by the government for women to use contraceptives to try to reduce the population. So there is kind of a broader context in which this is happening. And then questions around sexual health and safe sexual practices, questions around pregnancy, sterilization, so more permanent methods of contraception. Also questions around kind of bodily anatomy and reproductive anatomy, questions around menstrual health. There were actually less questions around menstrual health than we anticipated. A lot of them were more related to kind of family planning and spacing out births or contraceptives. A few questions around IVF. There were also some questions around marriage and relationships, and a few around miscarriage as well. Again, this is from a smaller set of women. So we did this work with 20 Rani workers. So this is a subset of the larger community, but it gives a bit of a taste of what the broader community might care about. So a lot of the women who participated in the study also not just presented questions they had around reproductive health, but also collated questions from their neighbors, from their family members, their sisters, and so forth to try to generate this list. And then just kind of one thing that we also found interesting was just when women use the system, because they also had a lot of family responsibilities, work, and so forth during the day. So often there was this uptick either very early in the morning or kind of around the time, kind of around 9 a.m., 10 a.m. after the kids had gone to school and their husbands were at work. So just like an interesting phenomena that we noted. And the questions themselves were also really interesting. So I'm giving a few samples to give you a sense of what are the kinds of challenges you might face when trying to design something that's culturally sensitive. And a lot of context gets lost in translation. So there is the original text for people who might know Hindi in the audience. But an example of a user query was like, that got very complicated was that, 15 साल की लड़की family planning कर सकती है क्या? Can a 15-year-old girl do family planning? This got complicated because the legal age for marriage in India for girls is 18. And then the assumption is that you're not having sex before marriage. So there are kind of multiple reasons why a girl might be thinking about quote unquote family planning. And the response that was generated was based on what the FINA team was used to sharing, which was, yes, a 15-year-old girl can think about family planning, but at this age, she should focus on education and personal development. But kind of given that the position that FINA took is that everyone should have access to this information, they did share that, okay, you should first consider non-invasive methods like condoms and or oral contraceptives, and then, you should talk to a doctor or a specialist. So this was kind of one sample of where things could get complicated. Another example is in the case of kind of relationships with religion. So there was one question which was, religion mein operation karna mana hai to kya kare? So what to do if surgery is prohibited in religion? And here also kind of the starting point, the starting assumption that FINA took is that, this is true, that your religion does indeed, your beliefs are indeed against operations or surgical procedures, which is not necessarily something you can take as is. But, if that is the case, then here are other alternative methods you could use for contraception that. And then an interesting kind of piece that was integrated is that you can seek guidance from a religious or community leader, as well as a doctor. And then, they had a link to their own telehealth team as well. And then one more example of, how cultural beliefs can play a role here. So in this case, the question was, in family planning, I only want a boy. So are there any solutions for that? And here it was again kind of trying to both address misconceptions, but also recognizing that there can be a lot of pressure for women to have a boy. And it kind of like tries to avoid the question of, gender kind of differences and patriarchal kind of assumptions in the society, but it basically says that, okay, there's no short way of predicting the birth. And then really the goal of this is to control pregnancy. And then there are people who try to predict whether it's a boy or a girl using certain kinds of methods. And it kind of explicitly does not mention what those methods are so that they don't try those, but, this is not foolproof, et cetera, et cetera. So these are, some of the kinds of questions that we saw, and the paper is going to be out soon and has a longer list of many different kinds of questions. But these are some that I picked because they reflected some of the places where these tensions can become very visible. And the thing we ended up doing was kind of trying to conceptualize cultural sensitivity as multiple layers that are integrated into each other. So you have kind of the broader societal layer, you have the regional, and then the community and the individual, each of which interplay with each other. And we took a lot of inspiration also from ecological models of care that kind of similarly look at a lot of these pieces. What's a little different here is that chat is a very one-to-one interaction unless you have other people who are part of that conversation. So finally, the interaction is very dependent on how the individual chooses to practice what is said in that conversation. So that was kind of central to what we were doing. But in terms of other pieces that we saw playing a role in our data, we saw, of course, like laws and regulation, medical consensus being important. And we explicitly mentioned medical consensus because you also have complementary medicine in this context. You have other kind of local sources of knowledge that people go to, which may or may not be reliable. But that is something that ends up shaping how people respond to the suggestions that a chatbot might have. Then there were the regional aspects of spoken language, the written script, also levels of healthcare access in that context, because that shapes what kind of suggestions you should give. And And then, of course, the community dynamics, the community beliefs, the dialect, the religion, the caste, the tribe, race, diet, and gender roles. And then at the more individual household level, you have the household dynamics, you have age, privacy practices, disabilities, income and occupation, marital status, digital literacies, health literacies, and medical history that can shape a response. So these were what emerged from our data. We imagine there might be many other things that might emerge in other contexts, but this gives us a starting point to start to conceptualize what happens. And then we have this very complicated way of thinking about some of these layers. I'll just kind of very briefly list some of these pieces, and I'm happy to have further conversation about it. But basically what we did is we tried to pull out different layers of the context and then different kinds of dimensions within that. So for instance, if you have a legal aspect, if you have medical consensus, spoken language, etc., what is the kind of example relating to that? And then what is the kind of design decision you might take, right? Or how could this potentially shape the architecture of the solution? So of course, there are things that might involve including certain information in the knowledge base, but there might also be certain kinds of choices to be made around picking the language model or the translation service. There might be decisions to be made around the kinds of interactions you include as part of the chatbot. There might be a dictionary you might need to include to swap out certain kind of language and so forth. So we have a more detailed list of suggestions in the paper, but this is just to give you a sense of what are some things you might try. And then kind of coming back to this question of how do you define cultural sensitivity in this context? So in our case, we defined it as a chatbot that provides verified information while considering the user's beliefs, attitudes, and behavior, which is shaped by their cultural backgrounds. So what this kind of basically means is that if you kind of go by this definition, you want to make sure you're understanding each of those components in the context that you enter. And again, we have more details about that in the paper. And a kind of broader question is that what if there are conflicts in values between the researchers and the communities? This can also relate to policy. This can also relate to stances that you might take in terms of sex before marriage, abortion, and things like that. The thing that we talk about also in the paper is kind of making your stance clear. And it's okay if sometimes there are conflicts, but what you'll often find is that there are certain champions within a community who may be aligned in certain ways, and kind of making sure that you're navigating those dynamics together very carefully is super important, so that you're not necessarily reinforcing things that are against your beliefs, but also being very mindful of what the cultural background might be in that context. And again, happy to have a conversation there as well. So those are some of the pieces critical to that project. And one of the things here too that we've been thinking about is around evaluation of these kinds of systems, and how do you evaluate cultural sensitivity and so forth. This particular set of metrics was defined with team members at Mina, especially their own set of clinicians. What we found is that, so we tried testing this with their clinicians. It got very complicated very quickly. What you've seen kind of repeatedly is that there's, like even with training, even with providing a structured way to collect this data, in practice, it's often difficult to assess a lot of these things when it comes to responses. So a lot of what we're doing now is kind of trying to further simplify this and see how we can improve these kinds of metrics for such solutions. But this was kind of like a ideal case. Here are the things you might want to measure. In practice, we found that it can be very difficult to actually evaluate along these lines. So that's something we are hoping to write about as well. But that's kind of a summary of some of the work we've been doing. I'll stop there. Happy to have more conversations on this topic and answer any questions.
I think, we have plenty of time for questions. So well, you can start. And if anybody has questions over Zoom, either feel free to speak out or just message on the chat.
So thank you so much for this talk. This was really wonderful. I'm interested in learning a little bit more about your first study and some of the scoring metrics. I completely understand that the scoring metrics are all very new, and we're, as a community, an academic community, but also society, learning what metrics work, which metrics are valued by people.
Mm-hmm.
So my first question was, when it came to the the SCORE metrics. So were those were evaluated on a Likert scale?
Yeah.
Okay, those were 1 to 5.
1 to 5,
scale.
yes.
Okay, and so my first question is about, I know you conducted the consensus sessions afterwards. Would you be able to talk about some of the findings that you have with those sessions with providers? Because that's really low integrator reliability.
Yeah. So this is something, I mean, to be very honest, we're also kind of still analyzing that particular transcript. But I think kind of high level, what we found is that in terms of, so safety was a little more clear. Consensus was surprisingly kind of inconsistent. And I think part of it has to do with also the choice of topic, because menopause is a condition that is that a lot of, I mean, our clinicians share that a lot of people don't get training for that, or it's something that that they might kind of get certificate. So one of the people on our team is NAMS certified, which is like the National Academy for Menopause. I forget what the S stands for, and she had a lot of kind of understanding of what is the right kind of response to be providing in this context. But for the other two, they were gynecologists, but not necessarily trained in menopause. And that, I think, played a factor as well. And in fact, initially we were thinking of getting residents to do the evaluation, and we're actually happy that we did with clinicians, because I mean, that might have been even more far off for all we know. So I think it'll be interesting to understand how literacies and kind of training plays a role in this context as well. The other thing is, I think, also just kind of styles of interacting with the patient. So for one of the clinicians, she really liked the kind of responses. She kind of had more straightforward, it's hitting XYZ, this is what I would tell a patient, and hence it's great. The other one had a lot more nuance in terms of what information she wanted to share with the patient. Her perception was, maybe you shouldn't share all of this information at once. It can be overwhelming. Maybe this kind of conversation around bone density doesn't need to be had yet. It could kind of scare off the patient. So that was a perspective that she was coming from. So there were a few questions where there was some alignment afterwards, but it was for much fewer than we thought, because they had kind of interesting stances. So I'm actually curious if this is necessarily because the focus was reproductive health, or if this is going to be true in other kind of healthcare conditions.
Being something that I don't think there are necessarily lots of answers. We just had a wonderful discussion about these, complex conditions, which in menopause is obviously a little more established. We know more, but still, there's not everything is evidence-based at this point. I wonder how much that's a big contributing factor too, and how we mitigate that.
Yeah, and I think it's also there were stances that they had around, okay, should we be suggesting hormone replacement therapy? They had kind of differing views on that. Also kind of, so there's also kind of the broader conversation that the medical community has been having around this, and then there's the broader conversation that the society has been having around this, and those kind of also intersect with this. So one of the things we are hoping to do, kind of, I mean, we'll see what happens. We've submitted a proposal, but we're trying to build a community platform for menopause, kind of taking inspiration from, platforms like Fendo and, conversations people are having in places like Reddit, to try to see if we can use this as a way to enable conversations with clinicians in the loop, but also leverage this as an opportunity to gather data on menopause, especially because we don't have that for underserved communities. And Atlanta in particular has a very diverse population as well. So we've been partnering with Grady Hospital, which is a public hospital, to do this research.
Thank you so much.
We have two questions on the chat. So the first one's from Rebecca. She says, "Hi, thank you for your talk. My question is about the second project with the chatbot. You had an example with legal implications, and I know this wasn't based in the US, but can you talk about the considerations with respect to user data privacy, if there are also political influences, for example, reproductive tracking, and risks of using this chatbot?"
Yeah, no, that's a great question. So right now, there is no personal data that's collected around from the user. So we don't ask questions around, let's say, their And this is both a challenge as well, right? So we don't ask questions around their age unless it seems very relevant to a question. And we'll be like, okay, like, if you're older, do X, if you're younger, do Y, kind of a thing. We don't ask questions necessarily around their marital status and so forth. So there are a bunch of questions that we could be asking, but we currently don't explicitly ask through the chatbot. And all of the user IDs are all the data is kind of saved anonymously, is encrypted. It means that you have limitations in terms of the amount of personalization you can do. So that's one tension that we've been navigating, trying to figure out. In terms of political influence, there is no established data privacy regulation in healthcare or otherwise, and whatever has been put out there is fairly weak. But on the other hand, there also isn't quite as mature a market around products for women. So so far, there are fewer channels that could leverage that data if it was to be generated. So I think it's something that we're going to see be a big challenge moving forward. For now, we've just been kind of cautious about what data we collect. We're trying to limit it to conversations that are more kind of generic and not revealing the status of a potential user. But this is a great question, and I imagine this will get very different if you talk about the US or the EU, for instance.
I have another question from the chat, but is there one here? Is there a question? Okay, so the question is from Muying. She says, for study 1, I have a question about the method/workflow of the chatbot. How many turns does the dialogue involve? Does the chatbot ask questions and collect more information from the user in order to better understand or better answer the original question? For example, to answer, am I in menopause? Will the chatbot ask more questions about the person's symptoms to evaluate her menopause status? Or is this only one round conversation?
So for the large language models that we evaluated, they all responded immediately with an answer. They did not ask for more data, more information. I'm not sure, and this is a challenge with closed models, right? I'm not sure if this is a deliberate choice, if this is, or is this for an interaction purpose so that someone just gets a response immediately, or is this so that they're not like kind of capturing data unnecessarily? I don't know, but they were all kind of immediate responses. That said, we also had, like I said, we had disabled kind of message history. So it was also assuming that each question is a new conversation. But for the second study, actually, this is something that we've been having a lot of conversation about, because right now it is a single kind of turn conversation, but we're also trying to figure out to what extent should we ask follow-up questions and clarifying kind of what their needs are. Mine also has a telehealth service. So, we kind of almost every other response has like talk to a doctor, and that can be very irritating for users as well. But it's like kind of a default thing we felt like we need to include, and it's something that we're also trying to understand to what extent that is required. There's also kind of this whole thing around when should a response be directed to a human? When is it appropriate for a conversational agent to respond to it? What is the kind of oversight that you need to be doing for all responses that are being generated? So those are a lot of the questions that we are now looking into for this particular study. So like I said, a lot more questions than answers. Yes.
Thanks for this talk. This is so interesting. So much of large language work might think it's addressing culture, but often it's just addressing the language and not the other things. One of the things I was wondering about was just whether or not we have adequate data sources about cultural beliefs that are available, as data or to help do things that are more culturally sensitive.
No, that's a great question. In our case, we actually generated a data set. So like the initial kind of assumption was that we are unable to find enough data sources about this. This is also a community that's often underrepresented in existing data sources. So even if you look at social media data and such, it's not going to be necessarily reflective of the kind of conversations they might have So that's why we had like these women from the community who were employed, who were generating a set of questions from both their experiences and from experiences of women in their lives. So I think that is one approach where you can kind of build those data sets. It's a time and financially kind of financially heavy process. But in this case, because it's kind of one of the first times something like this was being built in the Indian context, we felt like it was a critical resource in itself. That said, there may be other kind of proxy sources that you can use in other contexts. So like I mentioned, for the menopause study, we've been looking at social media data, but one of the things we're also trying to do is use that as a starting point in some of our participatory design sessions to see, and that's going to be with a lot of women who come from Black and Hispanic communities and come to Grady, are more likely to be on Medicare, and so forth, and trying to see if that is even reflective of the kinds of questions and experiences they might have. So I think there is going to be quite a bit of work around filling in those missing data sets over time. And I think that's just something, as a practice, we've been doing at our lab, and I'd love to see more people doing it. So I think we'll have to generate some of that data moving forward.
We have another question from the chat. So this again from Ying. She says, what different metrics or aspects would you explore with study one involving real patients instead of the models interacting?
Yeah, so I think a big part of what we want to do is so something similar in terms of understanding what kinds of questions women are likely to ask, because that's likely going to be framed very different from questions they might ask a clinician in a kind of hospital environment. So that's part of it. But in terms of the metrics, a big part of what we want to understand is like, is this response even understandable? Is this tone? Does it feel encouraging? Does it feel appropriate? Does the patient feel like their needs are met? So I think some of those pieces are also going to be part of the evaluation. The other thing also is that we have topics like objectivity and explainability that are part of the evaluation here, but that's not necessarily something that patients may or are equipped to evaluate necessarily. So it's something that may come up in a response and they might note. But if you ask a patient like, hey, can you tell us if there's bias in the system, I feel like that's also like an unfair exercise for them to have to do. Even in terms of explainability, I mean, you should be designing for those things in the first place versus telling them that, hey, kind of tell us if this is explainable enough and so forth. There's also this additional burden that is associated with I have to now ensure that these sources make sense to me when I should be getting accurate information in the first place. So those are some of the things we also want to try to understand from the participatory design workshops. Are they even interested in some of those metrics? Maybe they are, maybe they're not. And if they are, then that's great, we include them. If not, then we should be evaluating those in other ways. And then the user evaluation should be more focused on their experiences with kind of getting the information that they need, understanding the responses, and making sure they feel like this is socially appropriate and emotionally supportive. So those are some of the things that we're looking at. There is emerging work in this area. There have been a couple of papers that have come out looking at patient evaluations, but it's still a very early space. So there's I think a lot of work that can be done around developing appropriate metrics and making sure they're validated for these kinds of use cases. Yeah.
I have a question that I'm trying to figure out how to frame. So I really have a messy question. What I really loved with study 2 was your framing this on an ecological model and sort of thinking about the different layers. And that's something I've been doing training. I work in a very different space. But one of the challenges that often comes into play is for any decision that you're trying to help with, which I guess in this case is much more information centric, right? And it's often several levels of that model. And I totally understand the tension that you're talking about not wanting to get critical information where you really help someone with all the different layers and balancing those things. But I'm curious how you think about sort of the next step and how that might have come up, because I imagine with the value of community workers, right? They know the community, they can bring the resources in the community. And I imagine that's a lot of organizations like that. And so I'm curious how you're thinking about steps like bringing the ecological model into that and what's the balance of
Yeah, no, that's a great question. I think one of the things we're looking into is, if in some sense it's worth creating kind of buckets of like what kinds of user needs women are coming into using this chatbot with. So, are they looking more for just kind of informational support? So we see some women who are like, again, super users. They ask like hundreds of questions. And we are seeing this across multiple educational levels and multiple kind of socioeconomic status. And it's something that's quite interesting also for us. On the other hand, you have women who might kind of come in once and then have a question answered and then come in 3 months later and then ask another question. So a big part of what we're also doing now is evaluating the kinds of user behaviors when it comes to this kind of system. And then for those women, we do have survey data that community members have collected, and we're trying to kind of understand what are the patterns there in terms of user demographics as well. But that's one way to kind of think about it, where you have proxies around kind of the type of user and kind of leveraging that to make sure they get the right kind of information. The other thing we are also trying to see is, should we kind of have a purely health worker in the loop kind of model, right? So you have a health worker who is, the question comes to a health worker and the health worker is the one who's responding. It's just that they're assisted by the AI system to respond more quickly and get the kind of information they want to craft much more quickly. So we are experimenting with that model as well, where then you can do the kind of adaptation you want quite directly, but it's also, again, a more expensive process. It's a labor kind of intensive process. So those are open questions where we are trying to understand kind of different models of human AI interaction and where the large language model can and should sit in that ecosystem. Yeah.
So Paul was asked, is the intention for this to stay as more of like an focus system, or is the intention then to, so like see some of the questions are like, these are some modes of contraceptives you could consider. That here's where you could go, because again, I imagine like sort of how it fits into the network of the care community.
Yeah.
That stuff I'm curious if there's specific parameters that you've already defined.
Yeah. So it is. So the content generation is purely informational, but there is an aspect of connecting them to other healthcare resources in the ecosystem. So that includes guiding them on local government kind of healthcare services that are free or very affordable. It also includes kind of connecting to their telehealth service. There's also local gynecologists who they can be linked to, and we've been looking at that, but they're also very expensive. So not sure how, but if let's say it's a really severe situation, kind of encouraging them to reach out to them and maybe offering some sort of discounted resource. So a lot of that plays into the existing network that Mina has, the organization has, and plugging that into it. The challenge is as you scale, it becomes harder and harder to offer that kind of customization, that kind of resource support locally. It's much easier when it's within a region. So I think that's going to be the next barrier and question. And, that comes also with challenges around language, and communities are going to be different and so forth. But so far, it's been interesting to try to figure those things out in kind of this microcosm within a city, in India. Yeah.
No, I guess that's it. So once again, thank you very much, Dr. Ismail.